Ora, muito bem, sejam bem-vindos a este fim de tarde. Estávamos ainda à espera de alguém que vai ainda chegar, portanto, é provável que ainda está chegando gente, mas como já estamos bem para além do quarto de hora que costumamos dar em relação ao início, ainda há gente que está a pensar que é às 5h30, portanto, algum tipo de problema, portanto, está mais gente inscrita do que aquela que neste momento está na sala, mas temos que arrancar, senão temos que vos oferecer o jantar no fim, não é? Não será bem bom. I suppose I can now switch to English. I don't know. Maybe I think Pascal can understand. I'm gonna.
Yeah, my Portuguese is very bad.
Yeah, Portuguese is very bad.
Obrigado.
Well, in the beginning. And anyway, as you may be aware of from the dissemination of the call for the workshop, we are now addressing the organizational innovation in healthcare institutions from the information systems point of view, and that's why we have this workshop here. Tomorrow, you are, of course, invited to be in Braga and have this discussion from the management perspective. Okay, so with us today, we're going to have the directors of information systems. To start, we have with us someone that you, of course, know very well, the director of the Department of Information Systems. That's going to be in a moment addressing the audience with a welcome. And Pascal and Joris are our special invited guests, and of course, the president of the Institute, the Portuguese Institute of Business Process Management. That is also someone that some of you also know, because he works with you in the last phase of your program. And this initiative comes from a partnership between the Information Systems Department and the Portuguese Institute of Business Process Management, and that's why we have people here. So we are late, and I'll give the floor to the Professor Henrique Santos, Director of the Information Systems Department.
Thank you, Dinesh. Well, I will not take more than 2 or 3 minutes just to say you that the Department of Information Systems is very pleased to receive this workshop, and in behalf of our rector and the president of the school, I would like to thank you special for Pascal and Joris for being here with us. This collaboration is a strategic collaboration for the department and for the school, of course, and it's really a big pleasure to have you here. Thank you very much for coming. And we also want to thank the BPM Institute for making it possible and exploring this collaboration, because innovation is just this. Innovation is mixing people with different views of the reality of systems and making them working together. So this workshop is about it. It's taking people from different areas. In this case, healthcare, because it's a very strategic area as well. They need to cut costs, and we believe that the information system area has something to do with that. So I believe that for the students, for my colleagues, and for everyone that is listening or viewing these presentations, the information that we will receive here is really very important. So thank you for being here, and I expect you to take the most of what you will be hearing from our guests. Thank you very much.
Thank you. Thank you for joining. Just a few minutes before we give the word to and change the other place.
I can go for that.
But anyway, you can leave. I'm going to just spend a few minutes on the program, and of course we are kind of late. We'll try to finish by 7:30. But we'd like to address what we have been doing, or what we are planning to do in terms of the Portuguese Institute for VPM, and then we'll have the presentation with Pascal on process management models. Then yours will be addressing something that some of you have already had the chance of working and learning on the maturity models for BPM. And since it's a final work or the end of a program also of a master program, you may relate to what type of issues these kind of students and what kind of problems they address in Netherlands in the area of BPM. And after this, we'll have a presentation on strategic alignment with Professor Jorge Coelho, and finally the panel with some director of information systems. João Miranda is there. Then we'll have João Figueiredo that is coming. It's already arrived. Okay. So we have the people we need to have this workshop. Just a quick note on the special interest group. We are adding a special interest group on healthcare to the other ones we have been addressing in the past DPM conferences. So we're going to move to the 8th, 8 or 9? 8. Help me, someone, maybe 9? 9. Okay, so for quite some time, we have been addressing issues for small and medium enterprise, large companies, the local and the public government in roundtables we have in the BPM. These roundtables are now moving to special interest groups to be working all over the year, and healthcare and all the health issues, this is kind of a hot issue, right? Hot issue in all the terms and special financial terms to move research and other things around. So we are now with this workshop launching a special interest group in healthcare. Anticipating what we already have planned for the BPM Lisbon 2016, it will take place on the 17th and 16th and 17th of June. And this researcher and professor in the University of Liechtenstein is known many of you. Some of you have been working with the material he has edited or co-edited with Michael Rosemond from the Queensland University of Technology. So it's someone we'll have the pleasure of being with us for this 9th edition of BPM Lisbon. And he will be addressing 10 principles of good BPM. We'll have a master class as usual in the morning of the 17th. And in the afternoon, we'll have him again with a keynote address. So a more theoretical part. We have the practical part of these 10 principles on the morning. So set up in the agenda. Usually we have some kind of a discount, a small price for students, since the audience is mainly composed of students. But it's an opportunity to interact with some people that sometimes we just know by name or by book, and then he'll be with us. And that's all in terms of news. So I'll move now to Pascal for the presentation on process management model. Okay, so this is yours. This is yours. And this should be yours.
Can everything?
Yeah. And so people can hear you well. Microphone.
That's nice. I always like to stand up, move around a little bit. Can everybody understand me? Yeah, no problem. I know it's just say in which area I need to stay in a little bit. Because I typically always, when I do a presentation, I like to walk around, move a little bit, but I'm might get too far out. Can I do this? Yeah, still okay? There's a quality check. Okay, well, if I can move like this and a little bit also in front of the table, is that also good? So then we'll need to have that's good for the audience in the okay, thank you everybody for inviting me over, and especially for George and of course the director. Thank you all for having me over here. I will try to keep it to 30 minutes, but I'm going to start lecturing when I start keep on talking for about 3 hours. So, cut me down if it's needed. Basically, I'll start with who I am. I'm going to talk a little bit about research in standardization, process standardization in hospitals. And this is a few from the Netherlands. But before I start, let me introduce myself very quickly, briefly. Who am I? My name you already saw. It's Pascal Ravenstein. Ravenstein in Dutch. If you have any questions regarding the lecture or you want to have the slides, you can email here. Please don't call because I'm a secretary. And I'm actually the professor of the research group of process innovations and information systems at the University of Life Sciences in Utrecht. Anybody here been to Utrecht? That's the only one where actually the University comes with information systems. Many times. Many times. Well, it's a beautiful academic town in the middle of the Netherlands. We've got two major universities. Utrecht University, which is not on this slide, and our University of Life Sciences, and together with one campus. And we have about 80,000 students together and about 10,000. So you can imagine it's quite a big campus. On campus, well, students also living there, and they all come from the region. Besides that, I'm also the chair of the Dutch VPN Forum, actually a sister organization of the ICVPN, you know that. I am the editor of the Journal of International Technology and Information Management, which is one of the two journals of the Information Management Association, which is located in Los Angeles. So I'm happy to announce we always travel once a year to the United States. It's a lot of fun. And I do a lot of columns and articles here in the Dutch Professional Journal of Information Management. But briefly, Ryan, within our research team, I've got about 30 people who are deployment and finishing a master thesis and then start PhD project next year. So that's all about me. And of course, I want to know a little bit about you. So just raise your hand. Who's a student? Okay, university students is basically speaking. Who is faculty at the university? Okay. Who is from a hospital? Who's working in a hospital? Okay. Who's working in any other type of organization? Okay. I'm basically missing a whole bunch of ladies over there who are probably WhatsApping to their friends. I have to be able to tonight. Why? Don't worry about it. Students. So let's start off with the context of this presentation and what's happening. And I think it's happening here in Portugal as well as in the Netherlands. And that's that we're in the middle of a digital transformation. And as you see this, there's a lot of new innovation involving society, involving organizations, whether they're universities, healthcare organizations, governmental organizations, via IT, IT business. And there are new entrepreneurs taking the private sector out there. And of course, you all know Airbnb and you all know Uber, so there's a lot more happening. And basically, there are 5 major trends which are kind of enabling the digital transformation. So 5 major trends. And hopefully, you're all students, the majority are students here in an information systems environment, in hospital business. So I think you should be able to manage to go out to these 75 trends. Which are the 5 big trends to enabling technically is allowed to pull out tomorrow evening. Any ideas? I can learn the difference, but you show you 4. These are these 4. You recognize them? Of course, robotics you recognize. And robotics is something which, at least in the Netherlands, you see in healthcare is taking really applied. Also in elderly care. And of course, you see 3D printing. You probably have 3D printers over here in Portugal as well. And I remember that the first time I saw a 3D printer, I was in Stellenbosch University, South Africa, and they acquired one in the late 90s for $3 billion. And now I can buy this at a local supermarket and Amsterdam for about 500 euros. This one again is somewhat more expensive, so it's also a 3D printer. It doesn't print with plastics, it's something else. Anybody what? It prints food. This is a 3D food printer. It's experimental, it's at one of our university research centers. And of course, you might have heard that Google is sponsoring this type of research and already. I can also walk around. I can also do it like this. Then the people are even more awake. But Google is already sponsoring this type of research. And the most expensive hamburger ever produced was actually printed by a 3D food printer. It costed about $1 million to do this. But there is a lot of research going on in this area. And of course, I always say I love it because then after a very busy night at the university, I just open up my tablet, I go to an app and I say, okay, when I get home, I want a nice plate of pasta bolognese, start printing, stay connected to my car because we have a lot of traffic jams in the Netherlands, and you can kind of start printing when you think I'll be home at time. But of course, this is also very convenient in perhaps hospitals because you can start printing a la carte food. But before we all get too enthusiastic, this is also about 50 years in the future, I think. This, however, isn't, and this also isn't. This is then bioinformatics, and you see here nanotechnology. And these are typically technologies, domains of research, of products development, service development that are changing society rapidly. Just a brief example. For instance, how 3D printing is changing the medical healthcare environment. And you see here, this is a 20-year-old woman in the Netherlands who had a certain chronic disease. The bone layer of her skull was growing, and it had to be taken off because it caused all kinds of terrible side effects. And a new skull was printed. And no, it wasn't done with such a 500-euro printer. It was done with a very expensive medical 3D printer. But in hospitals, we see that this type of development, printing parts of body structures, bone structures, is becoming more and more common. Another one, and I'm not going to give examples of all of them, but let's talk a little bit about robotics. Robotics is becoming more and more important also. And here you see, because if we talk about robotics, a lot of people think it's something which is completely new. Well, perhaps there are a lot of new developments, but if you see this area here, the FDA in America already approved the Vinci surgical system in 2000, which is basically doing surgery via robotics. And in the last, well, when is this? I thought this was from 2014, 20,000 surgeries via robotics intervention has been performed already. However, nowadays, if we talk about robotics, we think a little bit more about this. Do you know this little robot here in Portugal? You've seen it on television or something. It's about, if it stands on here, it's about this high. It looks and walks naturally. But the most important thing, it understands human language. And we in the Netherlands are experimenting in elderly home cares because our society is very individual oriented. And when our parents get old, we shove them off in an elderly home care. Well, there's a lot of discussion on that, but we don't have enough nurses to take care of them. And these robots can be kind of a companion. And they understand emotions and they understand natural language. And they can help them at least not feel so lonely all the time. But we also use them in kindergarten to entertain children, to play with them, to learn them speech, to exercise, to dance, or to read a book to them. And yes, it's not common, but a lot of these developments are going on. So these are just some examples. And of course, these were four trends, and there's one which I didn't mention, and I think that's probably a lot closer to the Internet of Things and data analysis, and that's what I like to call big data. The entire trend of big data. We as a society, as humans, actually not only us as humans anymore, but also all the devices we've connected to the Internet of Things, are creating tremendous amounts of data, of information. And you can't read it, but what it says over here is that in 2003, let's say from the beginning of written time until 2003, all the information created in that time, which is approximately 150,000 years perhaps, but all that information created in that time was in 2011 created in 2 days. So think about it. All the information created since the beginning of written history to 2003, that amount of information in 2011 was created in 2 days. Today, it will be created in about approximately 4 hours. So in one working day, well, actually not we, mostly it's the Internet of Things, all the devices connected to it, my laptop, my smartphone, all the cameras on the highways, you name it, are creating data. Huge, enormous amounts of data. And what are we going to do with this? This is really impacting society. And also healthcare. Because IBM is working on Watson, the big supercomputer, not to have to play it games like it did with Jeopardy, but to be able to diagnose illnesses. And they say Watson is already better at diagnosing cancer than a general practitioner. Because Watson is able to analyze huge amounts of data each second that it's online. And continuously is analyzing all the new research papers that are being brought out, all the new medical treatments that are being brought out, the side effects, all the reports. A general practitioner can never do that. It's impossible. So this is typically going to have a huge impact on the healthcare value chain. There are people in the Netherlands that are predicting that the general practitioner, the general physician, is basically going to be a social worker. In the sense that he will be there as a friendly human face, but basically the computer is going to do the analysis. And now what's happening? We're walking around with Apple Watches. And maybe over here we're not doing it. And in the Netherlands, many of my students don't have them. But 4 weeks ago, I was in the United States, and about 1 in every 10 persons that I met had an Apple Watch. And an Apple Watch has sensors on the back. And it's continuously measuring your blood level, your heartbeat. And if I present this, because the vision of the CIO, Tim Cook, is that an Apple Watch will be the prime medical device in the world. And if I'm telling this, and I'm saying this to a healthcare audience in the Netherlands, the first reaction will be, but it's not accurate. No, it isn't. Actually, it's very inaccurate. But then again, if I remember the iPad, the first iPad, the first version, it didn't really work very well. The second version was already a lot better, and nowadays we can't work without. And I predict that within 5 years' time, the sensors on an Apple Watch will be calibrated on a medical standard level. And I'm not sure how many of you here know, but hopefully the people from the hospital will know, that together with the Apple Watch, something Apple also launched was the research kit. And the open data, sensory data, if you of course let people access it, is being analyzed by, for instance, Hoskins Medical Center in Boston, to help develop new apps for people with diabetes, for people with asthma, kind of like a preventive app, gamification IDs in there, so that you are able to live more healthy. So these are all these things that are coming together, but in the meantime, we do have a big problem. And that's if we look at today's patients, and we tend to today's patients with the same principles as we did with yesterday's patients, well, we pretty much rob them of tomorrow. Actually, the quote is by John Dewey, and he stated this about education. He actually said if we tend to today's students as we looked after yesterday's students, we rob them of tomorrow. But I think this is very much true for healthcare also. And a lot of the healthcare institutions I see in the Netherlands are very slow in changing. And of course, that's not strange because they have a lot of challenges. They've got a lot of internal challenges on their governance issues, their process issues. There's no transparency. People don't know who are responsible for certain things. So, and that's what the second part of this presentation is going to be about. So we're going to look specifically at a case study in Holland, the south of Holland. It's called Hospital Rivierenland, which is an area in the Netherlands. It's actually in a small village in Tiel. And that hospital came to us, to our university, and they had some challenges. And this is an assumption of mine that hospitals around the world have the same challenges, but perhaps the people over here can confirm that for me. But we see that they need to transform to process-driven organization. So their processes need to be more transparent. The information responsibilities, the information transparency needs to be clear. And healthcare is becoming more and more complex. It's becoming more complex. We know more, we can do more, but at the same time, everything goes faster. And there are privacy issues, and now we get cybersecurity issues with them. And we've got an aging population in Western Europe. In Japan, already 25% of all people is above the age of 65. In the Netherlands, that will be in about 3 to 4 years. And we don't have enough personnel to work in the hospitals to take care of the elderly people. So, and the number of specializations is increasing because we know more and more about all the different types of health issues. You need more specializations. And of course, the coordination responsibility and the governance of healthcare processes is becoming increasingly important. You may not know this, but the Netherlands has the second most costly healthcare system in the world. Only in the United States is more expensive. And we don't necessarily have the best healthcare system in the world. Luckily, it's not bad, but still. And what we do see is that more and more the insurance companies and the governments, they want to know where is the money being spent? And is the money spent efficiently? Or is it being spent basically just on administrative processes, staff, management, and stuff like that? And to facilitate this process-driven healthcare, we see that more and more in the Netherlands, we call it care pathways are being implemented. And a care pathway is typically from the diagnosis to recovery for a specific patient. So this was the challenges this hospital came to us with. And what we said is, okay, that's good. What we're going to do first is we're going to do a maturity assessment of your organization on BPM. Because they actually came to us at the university and they bought an in-company workshop, business process management, because they wanted to go model their processes. And we said, well, let's do a maturity scan first. And we scanned different roles within the organization. In this hospital, typically the IT department, quality and management. And management, not only the management as in the directors, but also the team leaders of the physical therapists, the team leaders of the nurses, etc. And we did it on 7 different dimensions. And of course, all of you know, at least the students, which dimensions these are, because today I walked up in the hallway here and I saw a poster hanging with typically the same spider graph. So you should all know that. Or no? Okay, well, I assume you know it. And if you see this, you see that this is typically the life cycle of process management. So you have to be process aware, you have to have descriptions, you have to measure them, you have to manage them. And if you do this in the right order, you can improve them, and then you go back here and you go improve. And then we have supporting dimensions, IT, and resources and knowledge. And one of the good things from this maturity scan was that we found that there's a difference in perception on several dimensions. And underneath these dimensions, we've got 37 BPM capabilities defined. And we use these gaps analysis here to do in-depth interviews with people at the hospital. And then we found very interesting things. We not only did the scan on the 7 dimensions of BPM maturity, we also did it on the process performance of the hospital. So if you typically look at a process performance, and then we're talking about a process which is supporting those care pathways, we see that, and we have defined 12 performance indicators. We also see that there are sometimes very large gaps in perception. And typically measurability, there's a big gap between what management thinks and what IT and quality thinks. And that's interesting. And here you see the same measurement of processes and the underlying capabilities. There's a gap between what management thinks and what the quality and IT people think. So this is interesting. We use this kind of to define areas, BPM capability areas, and probably George is going to call them organizational competence later on. And we define these to identify areas of improvement. And we started with 2 different projects. We started with a project to look at if the reference model, which was already available and developed by academical hospitals in the Netherlands, and this is actually a reference model from the architectural perspective, if this is also applicable to model the primary processes of the hospital. Now, that was one project. And we also looked at the possibility to use business rules management, and see if we could use that to standardize the risk screening processes. Because basically there was a tryout. If we were able to use business rules in standardizing the risk screening processes, then we would also be able to do it for other processes, all different types of processes. So let me quickly walk you through those projects. First, the validity of the Nixon's reference model for hospitals, with a specific goal to create transparency in the processes and to model the processes. Well, this is typically what we have already available. This is in Dutch, don't worry about it. I translated it to English for you. This reads a lot easier, don't you think? This is how they sell it. So they come with this to the hospitals, and the hospitals are saying, well, okay, that's very complex. Well, okay, it's not that complex. It's actually on a high level. It's a domain reference model. And they look at governance and accountability, cooperation, the scientific research, education, care process support. And you can drill down into this model all the way to the information objects. And if you look at the information objects, it's really defining specifically what is meant by a patient, what is meant by a surgeon, what is meant by a laboratory, what kind of information inputs and outputs are we needed. And what we did is, if we looked at this, we found that it's very much has an IT perspective, an information technology perspective, but it doesn't have a process perspective. And for people in quality department, IT actually also, and the management, it was very unclear how all these information objects underneath, specifically we focused on the care domain, could help create transparency. It actually created more and more questions instead of transparency. So we said, okay, we can't use this, we have to do something else. And just basically to give you an idea, well, it was bound to happen, but I saw some people sleeping in the back, so I thought that was needed. The domain reference model, as you can see over here, is a reference model from business activities and information objects. And actually, this is the most detailed level. It's a starting point, but they say it's a means to communicate issues in relationships between the different departments. But if you look at it, it's really information management. And if you come to a team leader, which is the manager of a department of nurses, and you're going to talk about information management, what do you think that will happen? Basically, they will fall asleep just like you did in the back. Or they go and say, well, I have some patients to attend to, so no, this is not going to work. And what it's not a detailed process model. It's not something you can use for electronic healthcare records specification. It's not something you can help you create transparency in regulations. It's also not an organizational diagram. Basically, it's a lot of things which is not. So we developed something else. We developed a process-oriented reference model, which looks like this. And again, don't worry, this looks very complicated if you try to read the Dutch version. So again, I translated it. So what we've done is we tried to develop a model for the care domain, only the care and cure domain, which kind of gets the essence of the communication in a hospital, which could be communicated to all the different roles and get a same level of understanding on what are we doing. And it's very simple. Basically, a patient is typically always referred to the hospital. It might be the ambulance coming into because you had an accident, but most of them, it's just the general practitioner. He's diagnosed you and says, okay, you need to go to the hospital. And he refers you to a specific medical attention. And what we've set in this model is now the first medical specialist to whom you are referred is the case manager. He or she is responsible for the entire case you're going to go through in the hospital. And up to now, within this hospital, normally the medical specialist would say, okay, I'm responsible for my own small part of treating you or planning, but not about the rest. And we've changed it. We now said, no, you're responsible for the entire case. You're responsible, together with the patient, for identifying the healthcare needs, planning it, linking it to the different services, monitoring progress, and evaluating. And at the end, you, as a medical specialist, are responsible for referral to the outside. In the sense to back to your home, back to the general practitioner, or somebody else. And this case manager, as part of these activities, will request specific services which need to be done. And we identified 4 high-level catalogs of services. So we've got services for consultation, services for examination, services for treatment, and services for nursing and care. And each time, this is the ordering and communication process. So the case manager requests a specific service, for instance, a consultation. The owner, the case manager of the service, is committed, is executing it, then communicates back that it's completed, and he's responsible for accepting it and checking the quality levels. And of course, you've got a layered effect. It could be that a medical specialist is ordering as part of the plan somewhere a physical therapist, and the physical therapist might need to order other services, like for instance, crutches or a wheelchair from another organization. Then the physical therapist is responsible for this part. And it goes on like that. So we've been looking at this, and we've been using this throughout the hospital. The good thing is patients are participating from the start in developing their own healthcare plan. See you. Thanks for being here. And of course, the patient is being treated, examined, and etc., etc. So the patient is very much participating within this domain. And the patient is also partially in control of this domain. Because typically in the Netherlands, specialist is discussing with the patient the best way of planning, the best way of treating, the different options that are available. So this is a high-level process which we have created and which is now being used throughout the university. And again, to emphasize, this model focuses specifically on the delivery of care to patients, or like Georgia would probably say, the organizational competence of deliver care to patients. We're not focusing all the other types of competences within the organization. And this hospital is now going, that's actually a new research project we're doing currently. We're looking at how this also interacts to the APQC model, but that's something where it's being worked on right now. So, this model, how do we use it? We use it for process analysis. We use it to identify the services, all the services in the 4 catalogs of services. We identify what are the inputs to those services, what are the outputs, what are the underlying activities. We can also use it to discover bottlenecks in processes. Typically, the responsibilities. That's one of the major issues in hospitals in the Netherlands, a discussion on responsibilities. Who is responsible for what? Well, here it's the case manager, everywhere. We can use it for the standardization of the service design, We can also use it for software implementation by identifying the services, the functionality needed for that, and then we could link, if we need to do that, back to the information objects of the reference domain model. We're using it to determine the added value for the patient, redesigning processes, and business IT alignment. Well, there's some of those issues. And we've been using it now for a year in this hospital. And what we see is that there are some very interesting first results. For instance, if we start looking at a hospital in this way, and we did it for the physical therapy department, we saw that the physical therapy department, we were trying to model processes. And typically the people who know that and have done that, you can model a workflow. And in the physical process department, we had 70 care pathways that could be modeled, 70 different models. But actually, if we started analyzing them as services, we only had 4 basic services. Yes, there was a lot of different business rules in there, but there were only 4 basic, so that's a huge optimization. We identified a lot of bottlenecks in the ordering blood process because responsibilities were not clear, which now means the service of providing blood during a surgery or something else is of higher quality. It's more efficient, it's of higher quality. Also, the process registration of medicine prescriptions in the polyclinic is optimized. The polyclinic is typically the day hospital. So it's in the same campus area as the regular hospital, but a patient comes in the morning, goes out in the afternoon. But as soon as a physician or a medical specialist in the polyclinic gives you a prescription for medicines, you have to go to another department in the hospital, which kind of basically acts like it is a completely different enterprise. And now we said, no, connected, if you look at the case management process, you are just providing a service in the entire process. You're not a different enterprise. And yes, the medical specialist who is prescribing the medicines, he is the case manager, so he is responsible for making sure that you get the medicines, the right medicines, and also take them in time as part of your treatment. So it helped us a lot. Now, there are some other results here too, but due to time issues, let's continue. So summarizing, this first project helped us make responsibilities clear within the hospital. Management and control issues are becoming more clear and easier to govern. We're starting a service model. So the services in this model are just the 4 high-level categories, but actually these are catalogs, and we're now building them up. And there could be about 90 services in a specific catalog, for instance, treatment. The order management and communication is very clear, which also means that we can put KPIs on that. The quality of the communication, and we can check that. The care pathways are becoming standardized. We've got less of them, and they're becoming more efficient. And yes, we have more focus on the patient and their value added. As I said, we did another project, and was the project looking at the possibility to use business rules to standardize processes. And like I just told you, yes, it's possible because we also used it at the physical therapy department. But it was an earlier project, and actually yours already published a paper on it. So that's you can find it on the internet if you want to. What we did was we looked at the risk screening process in the hospital. And in the Netherlands, there's a protocol which typically says, I think these are about 48 different risks. It's in Dutch, don't worry about it. The yellow ones are translated over here in English. And we analyzed these risk processes because the hospital said, well, for our accreditation, we need to model them. We need to model the workflows. And we said, well, I'm not sure why, but okay, let's do that. So if you look at the risk screening, and a risk screening is typically done when a patient enters the hospital. The first thing that's being done is screening on risk. Is the patient prone to falling? Is the patient underfed, malnutrition? Does the patient have a physical disability? And this hospital did the check on all these risks. So all the 40-something risks are checked when you come in. All of them. Doesn't matter which patient, all are checked. Well, if you look at the processes which we modeled them, You can see that this is for decognitus. You don't have to read it, but you see there are several decisions in there. It's a very complicated workflow model, and then we have it for falling down, and there's an entire risk process here. And yes, we did it for delirium, and there are different categories of risks here also you have to do. And then we did it also, this is sub-process for delirium, and we also another sub-process for delirium. And yes, we also did it for malnutrition, and this is an extremely complicated risk process. Well, you can basically see that if you as a nurse or as a medical specialist, if you have to know all these processes, you basically go nuts. Or maybe here in Portugal, you just learn them by heart. I don't know, but in the Netherlands, we go nuts. And we have typical culture. The Dutch always say, why do I have to know this? Why is it important? I don't think this is something I should do. And of course, we did it for physical disability also. So this is typically not the approach to take. And what we did is, after modeling all these processes, if you start comparing them, we actually found out that this is basically the process for screening a risk. You conduct an anamnesis, you do risk screening. Is there a risk? No, okay, observe the patient later on, because it could be the case that a risk comes up later on. And if there is a risk, yes, conduct preventive interventions. And this is a sub-process, so that you can see it over here, and this is a sub-process, and you can see it over here. And then we started going back to all the specialists in the hospital, and they said, well, actually, this is stupid, because the risk screening is already done here. So basically, we said, okay, this is the basic process. For all the 40-something risk screenings, this is the basic process. And here, if you don't have a risk, or once you do, you observe the patient. And of course, that's what we communicated back. Well, this is the basic process, very easy. The first thing we got to hear is, but what happened to all the checks, to all the items we have to check on? Well, we made a decision model for you, because basically, there are just business rules. And depending on the type of risk, you might have a standard. So for instance, for decubitus in the Netherlands, well, I think it's an international standard, but you might be able to tell me that more. There's a Braden score. And for physical limitations, there's a Bartle index. And this is a well-known index scoring rate within the international healthcare world. So you can use that and define rule patterns. And the rule patterns basically give you a very quick check on when are we going to use a certain screening. Which patients are we going to select for screening? So and we made all these business rules for all these 5 different risk screening processes. This is just basically to give you an idea how it looks, because it's all in Dutch. But this is the decisions within the risk screening process. And if you have this, you're not going to screen all your 136,450 patients coming into your hospital in a year, which they typically did in the SA situations, for only these 5. We had 41 in total. No, we're going to look at the factors, we're going to look at the business rules, and then we're going to only do the risk screenings which are really necessary, which turned out to be, in 1 year, 36,930. So that's kind of a reduction of 73%. And a 73% reduction saves up in a total of 1,658 hours, which in the Netherlands, by coincidence, is exactly the same as 1 full-time equivalent. So we just saved up 1 person on risk screening. And like I told you before at the beginning, we have a big shortage on people in healthcare. So it's not that this person is losing his job. No, he's got a lot of time on his or her hands free to do more value-added activities to the patient. So that's very interesting. So that's one of the 2 projects, that's the other one. And this is a nice quote by the head of quality, who said, well, if we look at this, seeing healthcare-related activities in the hospital as services, and then he reflects back to the first project where we did the service catalog, and linking these directly to performance goals, the concept of value-based healthcare is established. We now know which services directly are needed for the patient's health. And this introduces a new way of thinking in which each step in the healthcare process is reconsidered in terms of its value towards reaching the end goal. And again, I was preparing this, and this is a project we did in the Netherlands, and I've known Georgia very well. But this afternoon we're sitting together, and actually your mLearn methodology and what we've been doing overlaps partly, and I think can also help each other. Because yeah, you're also looking very much to the different organizational competencies and looking at reaching the end goals, the business objectives. And here we did something where the hospital was very glad about. I'm quitting over at this point, also due to the time. Any questions? Was everything completely clear? Yeah. Yeah. Well, this is one of the things. When this hospital came to us, they actually ordered a BPM workshop in company. So that's typically one of the master classes we give, because they wanted to raise their maturity level, their understanding of business process management, to be able to start projects and to hire consultants from the outside world. And what, after the workshop, they were so satisfied, they asked my research group, can you be the consultancy organization? I said, no, we don't do consultancy. We do education and we do research, no consultancy. But as closer to the workshop, we did the maturity scan. And I said, the maturity of this hospital, if you compare it to the benchmark in the Netherlands, is very extremely low. So if you start hiring consultants to come in, they will start doing all these activities, perhaps also reach some improvements, but at a certain point they will leave, and I can predict that your maturity will probably still be very low. And a lot of the things that will have happened might just disappear again. So my advice to them was, as part of a change process, don't get a bunch of consultants in, but start learning yourself. We are willing to do that as a university in small research projects. So we now have defined research projects each 6 months. And we've got students over there, and they're typically a couple of days a week at the hospital. We've got researchers from my research team, so yours and another one, who are supervising them, and sometimes they're also there at the hospital. And then step by step, we're doing these types of kind of proof of concept projects, where we try to learn together. And by learning, you see that more and more people are getting involved, more and more people are getting enthusiastic in the end. Sometimes in the beginning they are very, well, I've got it busy enough, don't come with your project over here to me, or they're very skeptical about it. Why should I model processes? Well, don't. But you do need it for accreditation reasons, so make it one standard process and start looking at the business rules, because all the protocols underneath, that's typically something a nurse will know, or a physician will know, because they're linked to the evidence-based practices in healthcare. So if you do a nursing education, or you do a general practitioner's education or something like that, you know those things. You don't want to be bothered with the process models. So then they're becoming enthusiastic again. So we're learning, and we're now busy. I think we started in 2012. So we've done about 4 or 5 projects. And now they recognize themselves, and that's actually one of the major stakeholders in those projects at the hospital. They said themselves, it will take us at least another 10 years to get everything fully up and running into a continuous cycle